Welcome to This Explainer. Today, we're going to unpack the absolutely fascinating and sometimes perilous biological hurdles that newborns face, literally right out of the gate. Okay, so let's dive right into this highly intriguing fact. Did you know that the vast majority of babies, we're talking up to 70%, experience a yellowing of the skin and eyes during their very first week of life? But here's the catch. Only about 10% of these cases are actually pathological. For the rest of them, it's really just their tiny bodies trying to adjust to life on the outside. To figure out why this happens, here's our roadmap for today. We're covering newborn baselines, growth restriction, the science of jaundice, bilirubin processing, the danger zones, and finally, light and blood treatments. All right, starting off with Section 1, newborn baselines and healthy growth. We obviously have to establish what normal actually looks like before we can understand when things go off track, right? So here's the target zone for a full-term newborn. This is our clear reference point. When a baby is born weighing somewhere between 2,500 and 4,000 grams with a length of 45 to 53 centimeters, we generally know their intrauterine development progressed normally. They hit the marks. Moving to Section 2, growth restriction, specifically IUGR. Now, what happens when a baby doesn't hit those critical baselines inside the womb? Well, this brings us to a condition known as intrauterine growth restriction, or IUGR. Basically, this happens when a newborn's weight falls below the 10th percentile for their gestational age. And you guys, this condition is incredibly serious. Babies born with IUGR face mortality rates that are 3 to 10 times higher than infants with normal development. Plus, their overall morphological and functional maturity is often significantly delayed. So the crucial takeaway here is that growth restriction isn't just some random bad luck. It's triggered by specific disruptions during pregnancy. We categorize these into the rule of threes. It could be maternal factors, right? Things like hypertension or diabetes. It could be placental factors, such as premature aging of the placenta or maybe blood clots. Or it could be fetal factors like chromosomal disorders or congenital infections. Any of these can cause chronic fetal hypoxia, basically robbing the baby of the essential environment they need to thrive. Let's shift gears to Section 3, jaundice science and the postnatal phase. We noted earlier that up to 70% of newborns turn yellow. But where does this yellow pigment actually come from? Well, newborns are born with a really high hematocrit, meaning a massive volume of red blood cells. But these cells have a notoriously short lifespan. Roughly 75 to 85% of this yellow pigment comes directly from the natural breakdown of those red blood cells. So the big question is, how exactly does the infant's body handle the cleanup? It's honestly like a highly specific biological assembly line. First, the red blood cells break down, releasing hemoglobin. That hemoglobin is then broken down into heme, which an enzyme quickly converts into a substance called unconjugated bilirubin. The liver must then process this bilirubin so it can be excreted entirely safely. To put this into perspective, this precise step-by-step factory line breaks down just 1 single gram of hemoglobin into 35 milligrams of bilirubin, and all of that has to be actively cleared out of the baby's body. Which perfectly leads us into Section 4, bilirubin processing and the liver's role. I really want you to notice the stark contrast here on this slide. This is the real battleground. On the left, unconjugated bilirubin. It's water insoluble, it's highly toxic, and because it's hydrophobic, it literally has to hitch a ride on a protein called albumin just to travel through the bloodstream. But on the right, we have conjugated bilirubin. This one is water soluble and non-toxic. So the liver's ultimate goal, its main job, is to turn that toxic fat-soluble unconjugated form into the safe water-soluble conjugated form so it can just be flushed away. The biological machinery that makes this magic happen is an enzyme called glucuronidase transferase. Think of it as this incredible piece of micromachinery operating deep within the liver's smooth endoplasmic reticulum. Without this crucial enzyme functioning efficiently, the unconjugated bilirubin simply backs up. It overflows right into the baby's bloodstream, and that is exactly what causes the yellow skin we know as physiologic jaundice. However, when jaundice is pathological, meaning it strikes way too early, like in the first 24 hours, or it just lasts far too long, doctors have to play detective. They categorize the breakdown into 3 distinct zones to find the exact bottleneck. Is it prehepatic, meaning there's excessive overproduction of bilirubin from something like blood incompatibility? Is it hepatocellular, meaning the liver's actual clearance machinery is failing? Or is it posthepatic, meaning the excretion pathways themselves are physically blocked? Now for Section 5, danger zones. What happens when jaundice is severe? The worst-case scenario is largely tied to one specific number, 20.
If unconjugated bilirubin levels cross the threshold of 20 milligrams per deciliter, the medical team goes on absolute high alert. Why? Because of a terrifying complication called chornicterus. This is exactly why pediatricians monitor a baby's yellow tint so obsessively. Remember how we said unconjugated bilirubin is fat-soluble? Well, at high enough levels, it can actually cross the blood-brain barrier. It literally deposits into the basal ganglia of the brain, leading to lethargy, seizures, permanent neurological damage, or even death. The whole game here is about protecting the developing brain from this toxic flood. Bringing us to our final section, Section 6, Light and Blood Treatments. Fortunately for us, modern medicine has developed some brilliant, totally non-invasive ways to assist a newborn's struggling liver before we ever reach that danger zone. By shining a very specific blue-green light exactly in the 460 to 490 nanometer wavelength directly onto the baby, phototherapy literally alters the molecular shape of the bilirubin right through their skin. It's almost like sci-fi. This magical light converts the toxic bilirubin into a harmless, water-soluble isomer called lumirubin. Essentially, this light therapy acts as an artificial liver outside the body. It makes the pigment water-soluble so the baby can just flush it away in bile and urine without needing the liver's glucuronyltransferase enzyme at all. How cool is that? So the medical strategy relies on a tiered response. It usually starts with breastfeeding, supplements, really just rehydrating the baby to stimulate the bowels and help clear the pigment. If that's not enough, then comes the phototherapy. But if the light therapy fails to bring the numbers down by 1 to 2 milligrams per deciliter within a few hours, or if those levels are critically high right off the bat, doctors have to initiate an exchange transfusion. This is the absolute final resort to physically remove and swap out the baby's toxic blood. All of this incredible biology leaves us wondering, if our baselines are so fragile and the cellular machinery is so easily overwhelmed, how might future therapies correct these molecular errors before a baby even leaves the womb? As we continue to unlock the secrets of fetal development, what unimaginable medical breakthroughs are just over the horizon? Thank you so much for exploring this vital topic with me today in this explainer. Keep learning, and I'll catch you on the next one.